of Rheumatology at Tokyo Women's Medical University School of Medicine. He holds a PhD from the same university and an MD from the Shiga Medical University. His research interests include administering and managing an observational cohort study in patients with rheumatoid arthritis, as well as pharmacoeconomic analysis in patients with RA. He's a member of several medical societies. He's worked as well as a visiting scholar at Stanford University School of Medicine. And today, we're privileged to hear him talk about the epidemiology of rheumatoid arthritis in Japan.
Thank you, Chairman. Mr. Chairman, ladies and gentlemen, I'd like to appreciate for giving me the opportunity of my presentation. So here is the agenda for my presentation. So the prevalence of RA over 60 years old in Japan was estimated using the National Database of Health Insurance Data in 2017. 825,000 patients were assessed as having RA, with an estimated prevalence of 0.65%. 3/4 were women. Prevalence by age was highest for patients in the 60s and 70s. Overall, 60.8% of the patients with RA were aged over 65 years old. So aging of RA patients is a world-leading problem in Japan. Methotrexate is the most frequently used CS dimers, followed by sulfasalazine, butyramine, tacrolimus, and iglatimod. MTX use was the most frequent for patients in the 50s, and the least frequent in patients aged over 85 years. Biologic DMARD use decreased with age. Oral corticosteroid was used in 40 to 50% of the patients in all age stratified groups. Biologic DMARDs were used in 23% of overall patients, and their use decreased with age. Younger patients were more likely to use TNF inhibitors and IL-6 inhibitors, while elderly patients were more likely to use abatacept. Proportion of the patients with osteoporosis, diabetes, cardiovascular and cerebrovascular diseases showed an increasing trend with age. However, depression trends were relatively constant across the age groups. So about half of the patients in Japan had visited only specialized institutions for RA. Overall percentage of patients who never visited specialized institution was 32% and increased with age. Concentration of rheumatologists in urban areas such as Tokyo, Yokohama, Osaka is one of the problems of RA treatment in Japan. So let's move on to the next topic. So results from randomized control trials are considered to have a higher evidence level. However, we should be aware RCTs include strict selection and exclusion criteria. Furthermore, RCTs are commonly evaluated for a short time period. Hence, it is hard to evaluate long-term outcomes in patients with RA using RCT. So our institute is the biggest center in the field of rheumatology in Japan. In other words, we had a responsibility to establish the first cohort for RA patients in Japan. So here is a list of representative RA cohorts in the world. These cohorts were divided into 3 types. First, All RA patients were registered, such as EOLA and Ninja in Japan, and Corona in the US. So second, biologic-specific databases like BSR, BR in the United Kingdom. At last, early RA patient-specific database. So lots of evidence were produced through this cohort database as well as RCTs. So EOLA was established in October 2000. We have learned a lot from the Aramis cohort in the US and imported this system with modification to adapt the clinical situation in Japan. EOLA is performed in a single institute. Data is collected twice a year from all RA patients who visited during this period. One of the most important concepts of EOLA is to register all cases in this cohort. So this means minimizing the selection bias. A database, sorry. A database consists of 3 domains, mainly self-reported assessment, physician's assessment, and laboratory data. Follow-up study for patients who did not visit is also performed by mail every 6 months. And now, 23 years of longitudinal data have been accumulated. Approximately 3,000 patients were registered in each survey, and the average response rate from the patients is more than 97%. Around 10% of the patients are switching in each data collection. And EOLA is supported by multiple pharmaceutical companies that suggest EOLA ensured the fairness of the research. So this slide shows a list of EOLA research that has been already published or presented in scientific meetings. So lots of research using the EOLA have been presented, and many articles have been published. I will talk about some of EOLA research from now. So as shown in this slide, a right figure shows the percentage of high disease activity based on DAS28 was 20% in 2000, and now this is only 1.7%. Percentage of DAS28 remission was only 8% in 2000, and now over 60% of the patients are in remission. So including low disease activity, around 80% of the patients are in relatively good condition. So EOLA clearly provides an improvement of RA treatment over the last 23 years. Left figures show the percentage of MTX user increased from 34% to 70%. Biological dimmers for RA had been introduced since 2003 in Japan. And this user also increased to 37% now. It is not that expanded use of MTX and biological dimmers have contributed significantly to the progress of RA treatment. On the other hand, the percentage of NSAID and steroid user gradually decreased. So we can see remission rates are gradually increasing no matter what remission criteria are used. So MTX was approved for RA in Japan for the first time in 1999. However, 8 milligram per week was the maximum dose at that time. So this limitation had been a major issue in Japan. So in 2011, 16 milligram per week has been approved at the maximum doses for RA. Effectiveness and safety profiles of MTX over 8 milligram until 16 milligram were examined in the EOLA. So these results contributed much to this approval. So in the last 20 years, along with the progress of RA treatment, joint surgeries for RA patients have dropped by half. So especially joint replacement in knee joints was getting decreased. So we also compared incidences of some major complications of RA patients with 5 big worldwide cohort. Corona in the US, SRR in Sweden, NORA in the UK, Corona International in Eastern Europe, Latin America, and India, and our EULA. At first, this is a result of infections. Incidence rate per 100 person years are shown in each cohort. Regarding hospitalized infection, there was no difference in each cohort. Tuberculosis tended to be common in developing countries and also in Japan. Herpes zoster occurred much more in Japan than in the Western countries. So next, results of malignancies. Regarding all malignancies, excluding skin cancer, there was no difference in each country. Skin cancer was quite rare in Japan. And the frequency of malignant lymphoma was almost the same in each cohort, and it was highly observed in approximately 10% of all cancers, which means malignant lymphoma in RA patients is an important issue in all regions. So next, results of cardiovascular events. Incidence rate of major adverse CV events, AMI and stroke in Japan were relatively lower than those in Western countries. So as previously, many reports, even in the EOLA, RA patients were more likely to die than the general population. So SMR over 1. So we show the results of mortality of RA patients in the EOLA. The mortality of Japanese RA patients until 2007 was investigated. A total of 287 death cases were identified. The standardized mortality ratio, SMR, of Japanese RA patients was assumed to be 1.646 to 1.90. So the main causes of death in Japanese RA patients were malignancy, CV diseases, and respiratory diseases, including respiratory infections, which were obviously different from those in Western countries. So significant risk factors for death were higher disability level, steroid use, and a history of interstitial pneumonia. So taking care with these risks in mind may help improve the prognosis of our patients. So it is our task to clarify whether the mortality of our patients improves along with the improvement of our treatment. So recently, we have updated the SMR and the cause of death in Japanese RA patients in the EOLA. So SMR remains high in RA patients, but is trending downward. We also found that disease from malignancy and respiratory disease remain high. So these results will be presented by Dr. Sugitani in our institute at this JCR meeting. So EOLA has provided real-world evidence responding to the variety of clinical questions which rheumatologists fill in daily practice quantitatively over time. EOLA clearly demonstrated the importance of RA treatment over the last 23 years. EOLA also demonstrated long-term outcomes, including disability and mortality of RA patients from the pre-biotic era to the biotic era. Some of the results obtained from EOLA differed from those reported in Western countries. An observational cohort study is necessary to evaluate the therapeutic strategy and to feedback the evidence to the patients in daily practice. So next. Next, move to introduce some represented Japanese RA cohorts. At first, Ninja cohort. Ninja was established in 2002. Ninja cohort is the largest database in Japan that collects data from all over Japan. So similar to the EOLA, Ninja also showed a progress in RA treatment over time. So next, the TBCR cohort. TBCR is a cohort mainly in the central region in Japan, specializing the biologic DMARDs or JAK inhibitors user. So there are various publications on biologic DMARDs in RA patients from the TBCR. So at last, ANSWER cohort in Kansai district, which is also specialized in biologic DMARDs or JAK inhibitor users. So there are also many reports on biologic DMARDs in RA patients from the ANSWER cohort. So we will work together to generate evidence for RA treatment from Japan. We hope our experience lead to the activity of cohort studies in various regions, and our experience result in improved prognosis for RA patients all over the world. Thank you for your attention.
Thank you very much for a wonderful presentation, and it's really an extraordinary body of work that you're putting together. So congratulations on that too. There are currently no questions online, so please, if you're online, feel free to ask a question. Are there any questions from the floor? If not, while you're thinking, I'm interested in a couple of things. I was interested when you talked about the use of conventional synthetic DMARDs in Japan. It is very different to a lot of other places, and we've always known about the methotrexate differences, but I noticed the absence of leflunomide, and I'm interested in that. And I'm also interested in the extent to which conventional synthetic DMARDs are still used in combinations in this country.
Yes, in Japanese RA patients, so leflunomide tend to get rise interstitial pneumonia. Mm-hmm. So many rheumatologists in Japan avoid to use leflunomide. So other DMARD, so such as tacrolimus or iglatimod, that's mean, I think so local area we can use as a CS DMARD. Mm-hmm. So totally much different from the Western countries. Mm-hmm.
There's a question online asking if you found differences between seropositive and seronegative patients in your cohort.
That's maybe in the EOLA cohort, maybe 80% of the patients seropositive RA patients. So that's similar to the worldwide cohort, I think. Just getting lower seropositive patients. Recently, because of the aging of RA patient, so seropositivity of RA patient getting decreased, a little bit decreased.
And there was another question online from asking about the use of biosimilar drugs in Japan.
Sorry?
Biosimilar DMARDs?
Yes. So now we can use 3 biosimilars. So infliximab biosimilar, etanercept biosimilar, and adalimumab biosimilar. So now clinical trial for IL-6 biosimilar. No.
And has there been much uptake into practice of those biosimilars? Do they represent a large part of the market, or are people tending to use the originators?
Because of the taking much time to give information to the patients. So, and nocebo effect, sometimes occur nocebo effects. So the patient, not so much market in Japan, maybe 10% or something like that.
That's interesting.
Similar, yeah.
Interesting.
Sorry.
Thank you very much. I'm Yamaoka from Kitasato University. I was a bit surprised with the increase of mortality in the respiratory disease patients. I think it was 22 to 24.
Yeah.
There was no decrease, but on the other hand, except it was an increase. So can you give us a comment on that? Why is that happening?
For Japanese patients, so yeah, ILD, interstitial lung disease, or chronic infection disease. So we have to take care of these patients. So because a lot of causes of death for respiratory disease, so we have to take care, manage.
So do you think we have more infections that could cause death?
Yeah.
Compared to like 2000 or 2005?
No, so constant. Yeah.
Yeah, so I was a bit surprised that there was no decrease.
Yeah, no decrease.
So we haven't really improved in taking care of the respiratory disease.
Yeah.
Okay, thank you.
Okay, so that brings this presentation to a close. So thank you again for a wonderful presentation.
Thank you.
I'm going to change microphone.